Hello and welcome to this lecture. Today we are going to discuss non-insulin anti-diabetic drugs, and we have different classification of the drugs. Let's discuss one by one. And number one, we have insulin secretagogues that consist of sulfonylureas and megalithinites. And when we take C, sulfonylureas, it is a class of oral hypoglycemic agents or medications that lower the level of blood glucose. As we know that most of them, all of them actually, they are responsible for decreasing the blood glucose level, and they are using for type 2 diabetic, and they are classified into first generation, second generation, and third generation. And there are different names mentioned in the first generation and second generation: tolbutamide and chloropropamide. Chloropropamide is used as in first generation, whereas second generation, which is the most commonly used, is glipizide, glyburide, glimepiride, glycoside. The main difference between both of them is actually first generation having poor kidney functions, and second one is improving the first generation drugs having better in improving the kidney functions. As we mentioned as well that patient that having renal malfunctions, we need to be careful when administer these drugs. So the second generation is the better form of the first generation. That's the main difference between them. When we see the mechanism of action, the main thing is that it decreases the ATP sensitive potassium. That is the main thing. And when it enter to beta cell through glucose transport 2, GLUT2 is actually glucose transport 2. They are responsible for increasing the ATP production through metabolism, and by increasing the ATP, they're responsible for decreasing ATP sensitive potassium. That is further responsible for depolarization of the cell membrane, and that depolarization is responsible for activation of the calcium channels and the increase of the calcium inside to the cell. And that calcium increase actually is mediating or responsible for increasing the insulin production. So the main thing, there are two processes going on at one time. One is that the increase of the ATP production through metabolism, which will be happen with the help of glucose transport 2, GLUT2. That in the second stage is going on to decrease the potassium, because then the potassium will be go outside, and the potassium efflux is responsible for increasing of the calcium going inside cell, which is explained in terms of the depolarization of the cell membrane. And that depolarization actually is responsible for increase of the intracellular calcium, which with the help of that exocytosis, and then uh, that increase of the calcium is responsible for the fusion of the insulin containing vesicles, increase of the insulin through exocytosis. To understand more in detail the mechanism, I just found this picture online, and if you take a look of that this is the glucose, and we know that GLUT transport is responsible for transport of the glucose. And then we mentioned that the metabolism will be increased. Why? How? But through Krebs cycle. Krebs cycle already discussed is responsible for carbohydrates, fat, and protein metabolism. And with Krebs cycle, I already mentioned responsible for producing ATP, adenosine triphosphate, and that ATP. Then, if you see that. I'm annotating them. This is the glucose, then Krebs cycle. With Krebs cycle, then ATP production. Then it's responsible for efflux of the potassium, and that efflux of the potassium going outside responsible for influx of the calcium, depolarization of the cell membrane. We can say that the membrane action potential changes. The increase of the calcium is responsible with the help of endoplasmic reticulum to secrete more insulin through secretory granules, or we can say through the process known as exocytosis. So that's it's very good picture I just found online. I just want to share with you that how this process occur, and this is the mechanism behind. What will be the side effects? The side effects include hypoglycemia, weight gain, and allergy. Contraindications: patient having hepatic or renal impairment need to be careful. Tall butamide first generation can be taken by elderly patient with renal impairment. This is very interesting. Although first generations having some renal complication, but still they mention for only for the people that are old age with renal impairment, tall butamide is still tolerable. Whereas the most of the new generation drugs are now uh, is helpful for kidney functions. They are not affecting. They are good and they are supporting the kidney functions. But still, tall butamide, especially for old patients and with renal impairment, we give this. Pregnancy and lactation is contraindicated. Then second generation, we already mentioned the names like glipizide, glyburide, and the differences between both of these drugs. The glipizide is short-acting drugs, only have half-life 2 to 4 hours, whereas glyburide have long-acting action and half-life is less than around 3 hours. How can we differentiate between short-acting and long-acting? Obviously, when short-acting drugs will be given, we need to give them like short-acting drugs 2 times in a day, like 10 to 24 hours. We need to divide the dose of the drug, whereas glyburide is long-acting drugs. One tablet is more than enough for a whole day. So that's patient compliance is very important in that context. Then the bioavailability of glipizide is 100%. When we see the absorption of glipizide and glyburide, they are absorbed in the gastrointestinal tract. Metabolism through hepatic metabolism, we know that. Elimination through urine, and glipizide urine extraction initially 10%, and whereas glyburide is actually with urine and with bile, both of them. The interaction, food interaction, we need to give them 30 minutes before the meal. And all drugs that are using for the treatment of diabetes, common side effects, so you can memorize them all. Like hypoglycemia, you will find most of them. Coma, seizures, neurological impairments are the common toxicities. You can make your own mnemonics like HCSN, HCS, and you can make your own mnemonics to memorize them. Then megalithinides, and what is the difference between megalithinides and sulfonylureas? Megalithinides bind at different part of the receptors than sulfonylureas do. The main difference: the interaction of megalithinides with receptors is not tight. The duration of action is also less than the sulfonylureas, and they are having less risk for hypoglycemia or mild hypoglycemia in post-prandial period, and sulfonylureas have high risk for hypoglycemia. So when we see, take a look of them, they are short acting, very short acting, as compared to the long acting sulfonylureas. Sulfonylureas, you can see that even the short acting is 10 to 24 hours and 12 to 24 hours, whereas these megalithinides are actually short acting and they have 4 to 7 hours approximately for repaglinite, and half-life is 1 hour. Bioavailability, they mentioned 56, and they also having low bioavailability like 56% and 73% respectively. So that's the main difference between these classification of drug. They are also having the absorption, fast action, peak action appear in 1 hour or less than 20 minutes. Metabolism through hepatic metabolism pathway. Elimination through feces or urine. Most of them are excreted through feces, and both are having same pharmacokinetic parameters. Food interaction 30 minutes before the meals, and the main difference between both classification of drug that they having low risk of hypoglycemia as compared to the drugs that patient having in sulfonylurea have high chances of hypoglycemia. So that's the main difference between them. Then we have insulin sensitizers. We have bigonides and thiazolonides. Bigonides, the mechanism is that they are responsible for hepatic glucose production. Their main thing is that they reduce the hepatic glucose, especially production of the hepatic of the liver sites, and reduce the absorption of the sugar in small intestine. So their main action is on the liver and on the small intestine, and they are responsible for increasing the susceptibility of peripheral tissues to insulin and promote anaerobic glycolysis. We have two type of respiration: anaerobic respiration and aerobic respiration. And in anaerobic respiration, the glucose break down without oxygen, whereas in aerobic respiration we have glucose breakdown with oxygen. So the main thing, these are the things that actually there are two type of respirations. And in this case, they mentioned that there is an increase of the susceptibility of peripheral tissues to insulin and promote anaerobic breakdown. Anaerobic breakdown without oxygen is required. So that's one of the key things that beagonites have. And the second thing is that the hepatic glucose production reduction is the most important thing in beagonites. And they are also responsible for inhibiting the glucagon release. Example, these are the most commonly used drugs, and metformin and fenformin are the commonly used. Fenformin is not used because of the toxic effects. Metformin is widely used, and I shared you one of the article I searched online that why fenformin is not used, and I'm going to share you. This is the article that I found. Fenformin induced lactic acidosis. That's one of the reasons that lactic acidosis they discontinue. And they mention a summary of the case study. I'm not going to go for the whole detailed case study. They mentioned that people using fenformin having issue with the lactic acidosis and challenging, and actually that is why it is discontinued. This article published in around 1960s. I just checked the dates, and 1993, and it has been now discontinued for long term. Even they mentioned that in the US market, although this article published in 1993, but in America it was already discontinued 15 years before. So you can see that it was discontinued in 1970s and 1980s. It already discontinued in the EU, in the US. But in the developing countries, the results, 1993 they produced that results. They mentioned this case study, and then it was now not using. But obviously, in the textbook they mentioned this drug, so I mentioned with you. The pharmacokinetics absorption in the small intestine, I already mentioned before that their effects is on the intestine or their effect is on the liver. So they are absorbed in the small intestine. Half-life is 1.5 to 3 hours. Distribution is the intestinal wall 100 times. Plasma concentration, and in kidney, liver, and saliva twice the plasma concentration. The pharmacokinetics furtherly explain that they are not metabolized in the liver, but not bound to the plasma protein and excreted through kidney. The clearance rate higher than glomerular filtration rate in that case in the pharmacokinetics. The overall toxicity producing anorexia, nausea, vomiting, abdominal discomfort, and diarrhea. And why we have abdominal discomfort? The answer is very simple, common sense, that it is absorbed in the intestine. It reduces we mentioned in the introduction that it increase susceptibility of peripheral tissues to insulin and promote anaerobic glycolysis, and they mentioned reduce the absorption of sugar in the small intestine. So their action on the small intestine is responsible for that abdominal discomfort, and that is why they cause nausea, vomiting, and diarrhea. So when you need to memorize the things, you need to correlate the mechanism with the effects. That's the key thing to memorize pharmacology. A lot of students ask me that the syllabus is too much. But actually the syllabus is, we know that there are so many things, so many clinical uses and toxicities you need to memorize. There are either one way you memorize through mnemonics. The other way is that you correlate the mechanism and then the effects. And then you need to join these all missing links. And that it is only possible if you thoroughly read the literature. If you just follow my slide, don't read the books, maybe you are unable to understand more in-depth knowledge. So you need to know this information. Then other toxicity included vitamin B12 deficiency, and vitamin B12 deficiency. That's why patients that are taking these drugs, they also take vitamin B12 because the deficiency of vitamin B12 is common, especially using metformin. And if the vitamin B12 deficiency increase, then it leads to neurological disorders like pain, and neuropathic pains will be increased. And then lactic acidosis, I already mentioned in one of the articles, especially fenformin is responsible for lactic acidosis. They are clinical uses. They are first line of therapy for type 2 diabetes. This is one of the most commonly used drugs, and especially in subcontinent in Pakistan. And I think it is also commonly used in Malaysia as well. Often combination with insulin secretagogues or thiazolonides it can be used in combination in chronic diabetes, or it is used for prophylaxis type 2 diabetes mellitus, like preventing the diabetes. Then thiazolonides improve insulin resistance, reducing the hyperglycemia. Fat metabolism can be improved by that, and having a positive effect on the endothelial functions. That is why it is very important. And the drugs using is pioglitazone, rosiglitazone, troglitazone. Most commonly using is pioglitazone and rosiglitazone. Troglitazone has been withdrawal right now. The pharmacokinetics, please you need to see the pharmacokinetics of all anti-diabetic drugs, because you need to know that when the drug will be absorbed, when the food will be given. I mentioned that the absorption will be within 2 hours, food may be delayed but do not have any bioavailability. The starting dose is around 30 milligram, then the dose will be maximum will be 45 milligram, and we need to give only 1 tablet in a day. So that is a patient and more prescribed drug, because patient compliance only need to take 1 time in a day, and that will be easy to manage the diabetes mellitus. Clinical uses to treat, it can be used as monotherapy or can be used in combination with metformin, sulfonylureas, and insulin. We will discuss the clinical management in our upcoming lectures. Then we have rosiglitazone, that having pharmacokinetics. The absorption is rapid, highly protein bound, metabolized. This is metabolized in the liver, and taking once or twice a daily, having 2 to 8 milligram of the usual total dose. The clinical uses of rosiglitazone, it is again same thing. We are talking about the monotherapy, or it is used in the combination with different drugs. The toxicities are fluid retention, macular edema, angina pectoris or myocardial infarction, or heart failure. So that is very important and tricky question. Why heart failure with the use of the rosiglitazone? The answer lies inside actually. If you take a look of the toxicity, why heart failure occur, we know that there will be increase of the fluid retention. We know that there will be macular edema. So obviously there will, if there is more edema, and then the edema is responsible for myocardial infarction or heart failure. So if you need to memorize them. If you know that fluid retention is the common toxicity, then obviously the fluid retention is also responsible for heart failure. So they are linked. These toxicities are linked with one another. So you can memorize by looking these toxicities and their link and their interconnections. Then we have alpha glucosidase inhibitors like acarbose and Megalithol. The mechanism they're mentioning that the alpha glucoside inhibitors block the enzyme. Absorption of the glucose will be delayed, as a result, lower postprandial glucose level. So they mentioned that there is one enzyme, alpha glycoside, and acarbose or Megalithol is responsible for blocking or inhibiting that alpha glycosidase enzyme, and that inhibition of the alpha glycosidase enzyme is responsible for producing the effect. And what is the function of alpha glucosidase? They mentioned that alpha glucosidase is responsible for breaking down the carbohydrates into simple sugars, and by blocking that enzyme that is present in the intestinal brush borders, we block them. That blocking is responsible for stopping the carbohydrates into sugar and glucose. So we are actually blocking that carbohydrate to break down into sugar and glucose, and that's through that mechanism it works. But it is contraindicated in patient having inflammatory bowel disease, yes, because obviously we are interfering with the intestine functions, and carbohydrate is not broken down into glucose. So for IBS, inflammatory bowel disease such as Crohn's disease, ulcerative colitis, we need to be very careful. Colonic ulceration, patient intestinal obstruction, or partial intestinal obstruction, or completely intestinal obstruction. So there, in that case, we need to be very careful. These four drugs, when we talk about acarbose having short acting, approximately 4 hours, half-life is 2 hours, bioavailability is extremely low, and maglitazole having half-life is around 2 hours. For absorption, less than 2% of oral dose of acarbose are absorbed as an active drug. So it means that they are not absorbing as an active drug. Very few amount has been absorbed with 2% dimension, whereas maglitol with saturable with high dose 25 milligram, the metabolism occurred in the GIT tract in acarbose, whereas in maglitazole it is not in the GIT. The elimination is through kidney. We need to take with food at the beginning of each meal, but it can lead to flatulence and diarrhea, abdominal pain, because we know that there will be undigested carbohydrates in the colon and the release of the gas. So because it interfering the carbohydrates to broken down into glucose, so because of that inhibition, it can cause abdominal discomfort or undigested carbohydrates. So diarrhea, abdominal pain is a common example, and then the release of the gases as well. Then the drug that mimic incretin effect or prolong the incretin affection. Incretin actually is the gut-derived hormone that is responsible that stimulate pancreatic insulin secretions to lower down the glucose level. So actually these drugs that act on incretin, which is a gut-derived hormone, and it consists of GLP-1 and GIP, glucagon-like peptide, are glucose-dependent insulinotropic peptides, because they are responsible for uh, production or stimulation of insulin. So they mention the name glucose-dependent insulinotropic. So tropic means the generation, the production. Wherever the word comes, tropic means the generation. How the incretin will produce the effect. So for example, that we can see that ingestion of the food, and after ingestion of the food is responsible for the release of the gut hormone incretin, and that incretin is actually responsible for the pancreas to secrete, you can see that, to increase the uptake of the glucose from the muscles, or the decrease of the glucose production by the liver. And in these both cases, then there will be decrease of the blood glucose. So see this step by step. Step one, if anybody then eat the food, obviously the food go to the GIT, that activate the incretin hormone. That activation of the incretin hormone is responsible that function in the pancreas to produce the insulin, the increase insulin from the beta cells, and that insulin increase is responsible for the uptake of the glucose from the muscles, or the decrease of the glucose production from the liver. So we know that the skeletal muscles and the liver are the site of the glucose productions, and then by decreasing the glucose production through liver, or by uptaking of the glucose from the muscles, is overall responsible for decreasing the blood glucose level. So these all mechanisms work through that hormone, what is the incretin, and that is known as the incretin effect. So how they work with GLP-1 or GIP, as we mentioned in the previous slide, glucagon-like peptide 1, GLP-1 are glucose-dependent insulinotropic peptide. We will discuss in up slides, like the GLP glucagon-like peptide. It is produced by the K cells in the duodenum and jejunum, having half-life less than 2 minutes. And the receptors are pancreatic B cells, adipose tissues, and the central nervous system. Whereas glucose-dependent insulinotropic peptides produced by the L cells of the distal ileum and colon, and they are having half-life around 5 to 7 minutes. And the receptors is islets of alpha and beta cells of the gastrointestinal tract and the central nervous system of heart, lung, and kidney. And the similarities that both are contribute to the incretin effect. but they are degraded, but they degrade by DPP, dipeptidyl peptidase 4, and other enzyme after secretion. So the main thing that is, if you see this mechanism of the incretin effect, these GLP-1 and GIP2 has been inactive with DPP4 enzyme. So the drugs, you can take a look of the drugs like glucagon, like peptides, and we all having the suffix tide, exenatide. You can see that suffix TIDE, or you can see liraglutide, TIDE. So you can memorize this suffix from them. So this is the easy way to memorize them. And the mechanism they are talking about, that, for example, the food has been taken, enter into the small intestine, secrete GLP-1 in response to food. So when person eat food, the increase of the GLP-1 in response to food is responsible for producing the decrease of the appetite through the brain, through pancreas by stimulating the insulin secretion and suppressing the glucagon secretion. So that's the mechanism, either by suppressing the appetite or through stimulate the insulin secretion and decreasing the glucagon level, or slowing the gastric emptying. So this work by three way: either decreasing the appetite, stimulating the insulin, or slowing down the gastric emptying. So we mentioned one of the example like axatonite. They derive from the axonite for peptide and from the Gila monster venom. So they have been taken from the venom, and they have 53% homology with native GLP-1. So actually they are structurally similar to GLP-1. So that is why it is used as substituent. And we know that they have been reduced by DPP4, which is very important. So we mentioned that 5 microgram of injection first within 60 minutes before breakfast and dinner is has been given. And we mentioned the absorption, that peak plasma level attained around 2.1 hours, because it can be administered subcutaneously. Because the route of administration is subcutaneous, so that is why the peak plasma level will be attained in 2.1 hours, and then they have been filtered through glomerulus before degraded by DPP4 or the other enzymes to smaller peptides and amino acids. The elimination is occurred through urine, obviously by the glomerular filtration, followed by proteolysis, and then eliminated through urine. Half-life is already discussed, 2.4 hours, but the adverse effect is nausea in that case. Then we have dipeptidyl peptidase 4 inhibitors. So the main action of them, that we know that DPP4 function. And if you take a look of the function before, we discussed already in previous slide that these DPP4 enzyme actually they are responsible for inactivation of GLP-1 and GIP. So when you please remember this slide, and then we see that the mechanism in later on. So to memorize the name of the drugs, very simple thing to memorize them. The suffix that has been using is leptin, sitagliptin. And I think maybe if you like tea, you know Lipton tea, so you can memorize these drug with the name Lipton tea. And when we take a look of this mechanism of action, we know that when we take the food, it goes to the small intestine. But the main thing is that they are blocking GLP-1. And the PP4 enzyme, we know that inactivates GLP-1. And that inhibition of that DPP4 enzyme further on increase the insulin secretion and suppress the glucagon action. So again, we need to go back to the previous slide. That will be helpful for easy to understand them. We know that the incretin effect is when a person is eating the food, it goes to the GIT, then the release of the hormone from the gut, and then we know that they are responsible for increasing the glucose update. But we know that the DPP4 enzyme actually is responsible for inactive the GLP-1 and GIP. That is the key step, this stage. And what happening that the drugs in that case, when we block them, they further on increase the effect of the incretin. So what these kind of drugs are doing actually, I'm going to the slides again. These drugs actually, they are blocking that DPP4 enzyme. We mentioned that DPP4 enzyme inactivate GLP-1. So if we inactivate GLP-1, then obviously the functions will be stimulation and suppressing glucagon. Stimulation of the insulin and suppressing glucagon will be not possible. And what happened that these drugs are blocking that that DPP enzyme, so that it further on increase GLP more. It will increase the production of GLP more and suppressing the glucagon secretion. So that's how they mention the mechanism. And the drug in this case is sitagliptin, and it is used in control type 2 diabetes. We mentioned the bioavailability having 87%, and can be taken with or without food, does not affect the pharmacokinetics, reach the plasma peak concentration in 2 hours, mostly non-metabolized and excreted unchanged in the parent compound in that case. Then we have the elimination through urine, half-life is around 12 hours. The adverse effect is upper respiratory tract infection, non-nasopharyngitis, or hypersensitivity or headache. Then we have sodium glucose co-transporter 2. And actually these transporters are present in the proximal tubule of the nephron. And we know that there are distal nephron tubule and we have proximal tubules. So what is the function of sodium glucose transport protein? And the main function of sodium glucose transport protein is that they are responsible for renal glucose reabsorption. They are in the proximal tubules of the nephron, and this transporter protein plays an important role in this class of drugs. We mentioned here 90% of the glucose reabsorption through that transporters. And then we have the drugs like canagliflozin and dapagliflozin, and then we have empagliflozin. The suffix to memorize is fozin, F-O-Z-I-N. In all of drugs, they mention the suffix fozin, so you can memorize with the suffix of that. SGLT2 inhibitors actually they work on the proximal tubules of the kidney, and by blocking the reabsorption of the glucose back into the bloodstream, thus reducing the blood glucose level. So what is happening that if you see that these are the SGL2 transport mechanism, these are the glucose molecule. So SGLT2 inhibit or suppress the action of these transporters, and they are responsible for reduce the glucose reabsorption, increase of the glucose excretion. So what will happening that these transporters work by increasing the excretion of the glucose, so that more and more glucose will be excreted through urine, and then there will be less absorption back into the bloodstream. So the reduction of the glucose reabsorption through that pathway and through SGLUT, because SGLUT we know that they are responsible for reabsorption. We mentioned 90% of the reabsorption occur through that mechanism. So these drugs actually inhibiting these transport mechanisms, so that there will be more increase of the or more loss of the glucose through urine, so that to maintain the blood glucose level. So they mentioned that SGLT inhibitors work in the proximal tubules of the kidney to block the reabsorption of glucose back to the urine, so that reducing the blood glucose level. So they are reducing the glucose back into the bloodstream and more excretion through the kidney. The drug it is used is canagliflozin, and this is the first anti-diabetic drug that approved for the prevention of cardiovascular event. So if somebody have edema and edema along with the heart disease plus the diabetes, then this drug is a drug of choice for that condition. Absorption is a little bit poor, 65%. Steady state concentration achieved after 4 to 5 days of daily dose. Metabolism occurs through glucuronidation, and then 7% undergo oxidative metabolism with the help of cytopathic cytochrome enzyme. Eliminated through feces and urine. Half-life is around 10.6 hours for 100 milligram of the dose. So thank you so much for today's lecture. Hope to see you again in more upcoming lectures.